Today I'm going to move on to CNS infections. Now, the central nervous system, as you all know, is composed of the brain and the spinal cord, and they are well protected by the bony structures like the skull and vertebrae. However, infection of the CNS is quite common, especially meningitis and meningoencephalitis. Meningitis can be caused by a variety of pathogens, which I'll be discussing as we go along. Meningitis is a very serious and life threatening infection. It may resemble flu like symptoms but can be fatal within hours if not diagnosed and treated on time. What is meningitis? It is infection of the meninges, as you can see over here, which is covering the brain and the spinal cord, or the fluid which is surrounding this area, the brain and the spinal cord. And as I said, a large number of organisms are responsible for this condition. They may be bacterial, viral, fungal, or other organisms like protozoas and rickettsia responsible for meningitis. By definition, it is inflammation of the meninges, which is the sheet covering the brain and the spinal cord, and the CSF, or the fluid that circulates in the spaces around the brain and the spinal cord. There are different types of meningitis. Viral meningitis. Now, viral meningitis is also known as aseptic meningitis, and this condition is less severe and more common as compared to bacterial infection, and generally it is going to resolve without treatment within a week or so. The best example are the enteroviruses, family of viruses which can lead to viral meningitis. There are many other viruses which can also cause meningitis. Then we have bacterial meningitis. Bacterial meningitis is a life-threatening severe infection, but fortunately it is less common than viral infection. However, it always leaves behind some degree of residual effect, like brain damage. There could be hearing loss, there could be learning disability, or it can even lead to the death of the individual. For bacterial meningitis, the most important causative agents are Neisseria meningitidis, Haemophilus influenzae, and Strep pneumoniae. And these three constitute 3/4 of all bacterial meningitis. And that there are certain factors which are making them more prone to meningitis, which we will be discussing in the next slide. Now, the other CNS pathogens besides Neisseria, Haemophilus, and Streptococci, they are E. coli and group B streptococci. We have already done group B streptococci in relationship to neonatal septicemia or neonatal meningitis. So group B is the one which is responsible for neonatal meningitis. Similarly, E. coli leads to neonatal meningitis. Listeria monocytogenes has also been labeled as a pathogen leading to neonatal meningitis. Then we have Strep epidermidis, or there is Mycobacterium tuberculosis. They can also cause meningitis. And with fungus, we have done Cryptococcus neoformans, and I've discussed this in detail again in relationship to meningitis. In your exams, you get a question on a list 2 bacterial pathogens responsible for, or 3 bacterial pathogens responsible for meningitis in children or adults. So you write Neisseria meningitidis, Haemophilus, and Strep pneumoniae. But when you get a question on a list 2 neonatal meningitis causing pathogens, then you have to write number 1, group B streptococci or Strep agalacti and E. coli. This is one of the very common part of your SCQ, and if you go through your UHS questions, you will see this question over there. Coming to the signs and symptoms of meningitis. Now, the signs and symptoms of meningitis can, as I've just said, can appear in form of like flu-like symptoms, but they are gradually going to result in the typical symptoms of meningitis. The patient may present with high-grade fever, there's severe headache with neck stiffness, and because of this, there could be vomiting. Light aversion is one of the common symptoms of meningitis. The patient, if not treated, becomes drowsy, goes into seizures, and there may be death of the patient, and these joint pains are also seen in some of the patients. Now, as I said, the symptoms can come very quickly or it can come slowly, taking a couple of days. Most cases of meningitis are seen in the first 5 years of a person, and the peak incidence is between 3 to 5 months of age. And this is because this is the period when the maternal antibody starts weaning off and the child starts producing his own antibodies. And this is the period when he is most susceptible to all infection. It is not just bacterial infection, but any infection can be acquired by the child in this period. Now, the virulence factors are seen, the common virulence factors with all these three pathogens. And the question is, why are these three bacteria more commonly associated with meningitis? The reason behind this is because they have certain common virulent factors which are going to play a role or which are going to facilitate disease production by these pathogens. Number one is capsule. As you can see on this slide, Neisseria, Haemophilus, and Strep pneumoniae, they are all capsulated organisms. So the capsule you are familiar with, it is antiphagocytic and it is going to obviously prevent the organism from being phagocytosed. Then IgA protease plays a very important role in all these three organisms. It is going to cleavage the IgA antibody in the respiratory tract and facilitates attachment of the bacteria to their specific receptor sites. Then there are pili, which are for attachment and colonization. We have done this in detail while we were doing general bacteriology. And these two are both, they are Neisseria and the Haemophilus are gram-negative bacteria, so they have endotoxin in their outer membrane and or lipid A, and this endotoxin or lipid A is going to be responsible for the variety of signs and symptoms which are seen with this pathogen. And because Strep pneumoniae is a gram positive bacteria, so it has teichoic acid and not pili, and it does not have endotoxin. So these are the virulent factors which are going to play a very important role in disease production by these pathogens. Now, with meningitis, the sample which you generally receive in the laboratory is the CSF. CSF examination is very important because this is the first test which you are going to do, and you are going to come up with presumptive diagnosis of the of the disease, and you have to give your diagnosis to the clinician. You have to differentiate between bacterial meningitis and viral meningitis on the basis of the changes which you see in the CSF with infection by these pathogens. Now, if you look at this slide, the normal cells are 0 to 5 per micron liter. Protein level in CSF normally is 15 to 45 milligrams per deciliter. The glucose level is 45 to 85 milligrams per deciliter. With bacterial meningitis, or we also call it septic or purulent meningitis, the number of cells on this on total leukocyte count or TLC, the number of cells are markedly increased. They can go up to as high as 20,000 cells per micron liter, and they are mainly neutrophils. The protein levels are also very high, whereas because these organisms are extracellular, they are going to multiply, use up the glucose in the CSF, so the glucose level is going to fall down. With viral meningitis, which is also known as aseptic meningitis or meningoencephalitis, the total leukocyte count is raised, but it is not as high as what you see with septic meningitis. And the cells which you see are mainly mononucleocytes, and the protein levels again are raised, but the glucose level remains normal because viruses are intracellular pathogens, so they are multiplying within the cell and they are not utilizing the glucose which is present in the CSF. If you look at this slide, this is showing you the differences between viral meningitis and bacterial meningitis, plus it is also giving you fungal and tuberculous meningitis. So the CSF changes which you see in these conditions, number one is the total leukocyte count. With viral meningitis, as I said, it is increased, but it is not as high as what you see with bacterial or purulent meningitis. It is generally more than 2,000 cells can go up to 20,000 cells. If you look at the DLC or the differential count, the lymphocytes are mostly seen in viral meningitis. With bacterial meningitis, it is mainly neutrophils. Mainly neutrophils are seen. Fungal meningitis, you also see lymphocytes, and with tuberculosis, because macrophages are mainly involved, so you're going to see monocytes. Glucose level with viral meningitis remains normal, but with bacterial meningitis, it is going to fall below the normal levels. And then we come to the proteins. In case of bacterial and viral infections, the protein levels, the bacterial infection and tuberculosis, they are increased, whereas the protein levels with the viral meningitis is also increased to normal, but it is not very high. With fungal infections, it generally remains normal. So you have to keep this in mind while you are differentiating mainly between viral and bacterial meningitis. The clinician wants to know whether it is viral or bacterial meningitis within 2 hours of sending the specimen, so that he can start the treatment accordingly. Coming to the laboratory diagnosis of meningitis, the traditional bacteriological methods are direct bacterioscopy or microscopy. When you get the CSF in the laboratory, once you have done the CSF examination, the next thing you do is gram staining. On gram staining, you're going to look for the typical morphology of the organism. Then you're going to put up the relevant cultures, blood or whatever the selective media is inoculated, and on the second day, you're going to look at the colonial morphology, then you're going to perform the bench test and the biochemical test, and you're going to come up with the diagnosis of that pathogen. From this, you are also going to perform immunological tests, especially if they are all capsulated organisms. So you're going to perform quelling reaction. You can also do latex particle agglutination test or co-agglutination test, ELISA techniques or CIE, etc. We'll be discussing the lab diagnosis of each organism separately as I move along. And then we also do polymerase chain reaction or PCR to find out the genome of that pathogen. So this is the basis of meningitis. You have to keep this in mind as we discuss each organism causing meningitis separately. There's a test which is performed for meningitis which is known as the glass test. Now in the glass test, what we do is that you press generally with meningitis there is appearance of rash, especially when there is sepsis due to meningitis, bacterial meningitis. So when there is rash with meningitis and you press a glass firmly against the rash, if you see the rash clearly against the glass as you see over here and it doesn't fade away on pressing, it is a sign of bacterial sepsis due to meningitis and needs immediate treatment. But if like this, if this fades away, if the rash fades away like this in this case or over here, then it is rash due to some other reason and it is not meningitis. So with this I'm done with general meningitis, and now I'm going to, in the next lecture, I'll be discussing each of these organisms separately.